Okay. Explain the nature. Oh, okay. Explain the nature of the autism spectrum disorder and how comprehensive evaluation can be helpful. So this patient impaired social interaction, preference for solitary play, restricted interest, food selectivity, behavioral rigidity, insistence on food being organized in a certain way, raise concern for autism spectrum disorder. Although many children with ASD are brought to clinical attention sooner by age 5 due to language or intellectual disability, individuals on the mild individuals on the mild end of the autism spectrum may present later after social deficits affecting power relationship become more noticeable. In the scenario, the most appropriate course is to empathetically listen to both parents' points of view and provide information about spectrum of ASD manifestation and how further evaluation and early intervention can helpful. The diagnosis of the ASD can be made clinically, but comprehensive multidisciplinary evaluation including assessment structured assessment of the social language and intellectual development, in addition to hearing, vision, genetic testing can aid in confirming the diagnosis, specifying the degree of the impairment, and procuring the direction individualized services. Okay. Yes. Okay. This patient's excessive preoccupation with perceived defects in her breast shape, size, and symmetry is consistent with body dysmorphic disorder. Patients with body dysmorphic disorder typically engage in time-consuming behaviors to conceal the perceived defect and frequently become socially isolated due to fears that others will see and reject them because of their deformity. Most patients have minimal to no insight into true condition and seek surgical and dermatological treatment to correct their perceived flaws. However, surgery should be discouraged because patients are rarely satisfied with the results and body dysmorphic disorder symptoms may worsen following the operation, leading to additional inappropriate cosmetic procedure. Responding to patient with body dysmorphic disorder who requests surgery and inquires requires who requests surgery requires engaging in patient are trying to build rapport before discussing the recommendation to avoid surgery. The most appropriate initial response would be to acknowledge the patient's distress and focus on the impairment it caused without validating or dismissing the other's belief about appearance. In this patient, acknowledging how her time-consuming appearance concern have negatively impacted her social life can help establish a therapeutic alliance and lay the foundation for educating her about BDD and treatment option. Okay. This patient's sad and hopeless mood anhedonia, no interest in family or friends, low energy, impaired concentration, sleep difficulty, meet the criteria of MDD. Post-stroke depression is rarely one-third of the stroke survivors. Post-stroke depression occurs in nearly one-third of the stroke survivors. However, it is often overlooked in patients recovering from stroke, contributing to reduced quality of life, decreased adherence to treatment, poorer functional outcomes, and increased mortality. Early treatment of post-stroke depression with antidepressant, SSRIs, and psychotherapy to alleviate depression symptoms and enhance physical and cognitive recovery. Therefore, treatment should be offered without delay. Patients recovering from a stroke and its complications experience a wide-ranging and difficult emotion. Thoughtfully initiating the topic of a depression treatment should include empathically validating a patient's experience. Experiencing depression after a stroke is common. followed by education about the treatment option. And there are treatments that can help. There are treatments that can help. Okay, next. Is it illness anxiety? Are you thinking about D, persistent complex bereavement? It is not. Yes. Loss of interest, inability to concentrate, low energy. Yes, I think so. Okay. In the absence of underlying medical illness, these patients' weight loss, low energy, impaired concentration, loss of interest, guilt, psychomotor retardation are most likely due to major depression. His conviction that he has brain cancer despite normal test result, that cancer is a punishment for sins he committed as a child, and a delusion represents a delusion that specifies the subtype of major depressive disorder with psychotic feature. In the severe subtype of unipolar major depression, the depressive episode is accompanied by delusion and hallucination, typically with depressive themes deserving punishment, worthlessness, and nihilism. Identification of psychotic feature is important because treatment with psychotic depression is different than that for non-psychotic depression. First line treatment for major depressive disorder with psychotic feature is combination pharmacotherapy with antidepressant and antipsychotic with ECT. Okay, and it's not illness anxiety disorder. Patients with illness anxiety disorder are excessively concerned about having a serious undiagnosed medical condition. Somatic symptom disorder is characterized by excessive anxiety and thoughts about seriousness of at least one somatic symptom. Neither diagnosis explains the patient's severe depression associated somatic delusion and delusion of guilt. Okay. Okay, opioid account for three-quarters of all fatal prescription drug overdose. An early identification of misuse is critical and in ensuring about patient safety. Opioid misuse is defined as taking the medication in a way that deviates from the manner, overuse, diversion, and purpose relieve anxiety for which it was prescribed. Obtaining opioids from multiple prescribers, taking non-prescribed opioids concurrently, using recreational drugs or other non-prescribed controlled substance also constitute misuse. The prescription drug monitoring program is a helpful tool for detecting misuse. The state-specific prescription drug monitoring program is a record of prescribed drug control substance that the patient has obtained, including the quantities, dates of prescription were filled, and prescriber information. The prescription drug monitoring program can identify patients who are receiving opioids from multiple prescribers and suggesting possible overuse or diversion. The database should be queried before each refill to help ensure appropriate use. Okay. Okay, if the patient is okay, potential medication adverse effect teratogenicity should be considered when maintenance therapy for bipolar disorder is prescribed in the reproductive age woman. This patient with bipolar disorder is taking the mood stabilizer valproate. However, patients who take valproate in the first trimester, the critical period of organogenesis, have an increased risk for neural tube defect, anencephaly, myelomeningocele, making it poor choice. The mood stabilizer lamotrigine was Lamotrigine has a favorable pregnancy safety profile and can be used in the maintenance phase of bipolar disorder, protecting against both future depressive and manic episodes. Atypical antipsychotic quetiapine risperidone may also consider for maintenance therapy because can also they also have no increased teratogenicity risk. Patients on teratogenic mood stabilizer valproate, which who wish to become pregnant should delay pregnancy 3 to 6 months to allow the slow and the carefully observed cross-taper to new medication lamotrigine. If stability is maintained, pregnancy can be attempted. Next. He has neuroleptic malignancy. He's on he's on antipsychotic. The doses have changed over last 2 months, and their fever, hypertension, tachycardia, and there is tremor. Okay, deep tendon reflex 2 plus, or it is serotonin syndrome. No, no, no. Serotonin syndrome comes with the SSRI, not with antipsychotic. Okay, so this patient taking antipsychotic medication, fever, altered mental status, tachycardia, tachycardia, hypertension, and muscle rigidity. These features are consistent with neuroleptic malignant syndrome, an idiosyncratic drug reaction to dopamine antagonist. Although symptoms of NMS typically begins within 2 weeks of initiation of precipitating agent, they can occur at any time during treatment. Sustained muscle contraction can lead to muscle breakdown that results in many of observed lab anomalies, including elevated CK, electrolyte abnormality, hypocalcemia, metabolic acidosis, and elevated BUN and creatinine. Non-specific lab abnormalities include leukocytosis with a left shift and slight protein elevation in the CSF, possibly reflecting increased neurometabolites and elevated liver enzyme. Discontinuation of the antipsychotic is the single most important intervention. Additional treatment often includes hydration, IV fluid, cooling, and medication to control agitation. Benzodiazepines and decrease muscle contraction like decrease benzodiazepine and dantrolene can be given. Okay. For treatment, we can use benzo, dantrolene, IV fluid. Okay. If four symptom is present, my heart is racing and my heart is racing like palpitation, and he this sorry, yes, and at point like he stares into the space. This is depersonalization or derealization thing. You are you thinking otherwise? I don't know actual answer. I am just asking. Where is the trauma? Oh, like has 3 months ago. He filed a divorce 3 months ago, and post traumatic. What is the timeline? 6 months. Yes. Okay. When the set stops, the answer starts. Where is the intrusive thought? Yes, maybe you are on. You are in the right track, but I drag you in the wrong track. Okay. So this patient with a history of exposure to intimate partner violence has several features suggestive of PTSD, including sleep disturbance, poor sleep, panic awakening, and dissociation, like monetarily Dissociation, momentarily staring and unresponsive, negative mood, and hypervigilance, increased startle response when nearby door slams. Other characteristic features include flashback, intrusive memory, avoidance of remainder of traumatic event. Patients with PTSD commonly experience depressed mood, irritability, and anxiety, and frequently have classic mood symptoms: insomnia, fatigue, impaired concentration. Patient may be reluctant to disclose trauma, so physician must remain alert to signs and symptoms of the PTSD and provide further assessment and treatment. A trauma focused CBT and antidepressant are the first line. Okay, depersonal. Okay, okay, okay. Depers. Okay, depersonalization or derealization. Feeling detached from one's body, experiencing surrounding as unreal, and is considered a part of PTSD and is not diagnosed as a separate disorder when PTSD is present. The specifier with dissociative symptoms can add it to the PTSD diagnosis when such symptoms are persistent. And the major depressive disorder would not explain this patient's panicked awakening and heightened startle response or dissociation. Negative mood states, decreased interest in activities, and emotional detachment are common features of PTSD. Next. Okay. Yes. Patients with panic experience unprovoked panic attacks at any time during the day or night. These patients' nighttime panic symptoms are most likely due to nightmares and related to PTSD and unrelated to PTSD. Related to PTSD.